Hi, my name is Norm Sweet. I'm the Director of Behavioral Health for Harbor Health Services Community Health Centers, and I'm here today to talk about trauma-informed care. So what is trauma-informed care? What is trauma? How can trauma be experienced? Why is trauma-informed care so important? How can trauma affect staff? How can we respond? In conclusion, so what's trauma-informed care? Coming from SAMHSA.gov, an organization that provides trauma-informed care has every part of an organization trained on at least the basic understanding of what trauma is, how trauma affects the lives of patients and staff, and how symptoms can present themselves. Trauma-informed organizations practice with the understanding of the vulnerabilities and triggers that may affect patients seeking services so that patients feel safe, supported, and not re-traumatized. What is trauma? A person can experience trauma when experienced, witnessed, or confronted with an event or events, and actually a perceived threat of death, serious injury, threat of physical integrity of self or others. Responses can include intense fear, helplessness, shock, or horror. Children can also become disorganized or agitated. I pulled the symptoms out of the DSM-4-TR. Does not necessarily mean that somebody who experiences trauma or is having a trauma reaction is going to be struggling with post-traumatic stress disorder or acute trauma or acute stress. But there may be symptoms of trauma response. So, how can trauma be experienced? Recurrent and intrusive distressing recollections of the event, such as images, thoughts, or perceptions. Children may repetitively replay these themes or aspects of the event. For example, if somebody had a car accident and they're driving, and something happens and it reminded them of a car accident from before while they're driving in the future, that could shake somebody up. There are people who pull over shaking because it reminded them of the past trauma. There could be recurrent distressing dreams of the event. Children may have frightening dreams without recognizing the content. Any patient, whether they're adult or children, who has a bad dream or a nightmare may or may not connect it to the actual trauma. It depends on how they interpret the dream. They might be acting or feeling like the traumatic event was recurring, such as reliving the event, illusions, hallucinations, dissociative flashbacks. Dissociative flashbacks are kind of like zoning out and remembering what happened. Sometimes somebody might seem spacey. They might be off in La La Land, but they might actually be re-experiencing the trauma. Children may reenact parts of the event. Play therapy is often used to help support children act out traumatic experiences. Now, the last two I starred, particularly important for staff to remain cognizant of when providing services to patients. These are very important. One, a patient could have intense psychological distress at exposure to internal or external cues, symbolizing or resembling aspects of the event. There might be physiological reactivity on exposure to internal or external cues, symbolizing or resembling aspects of the event. Psychological distress might be significant anxiety. Somebody might also feel shame. Physiological reactivity might be trouble breathing. Face might feel flushed. Shoulders might feel tight. Those are examples when they're in the exam room, just to keep cognizant that sometimes some of the symptoms that we're seeing might actually be trauma responses. How else can trauma be experienced? During the event or afterwards, dissociative symptoms may occur, such as subjective sense of numbing, detachment, or absence of emotional responsiveness, um, reduction in awareness of the surroundings, like being in a daze, zoning, derealization, unreality of outside world. The outside world all of a sudden doesn't seem real anymore. Depersonalization, they might feel disconnected to their own self. And then there's dissociative amnesia. This happens a lot with folks who have experienced trauma, where they might not remember certain aspects of what happened. Persistent avoidance of stimuli associated with trauma and numbing of general responsiveness that was not present previously. And again, I starred several areas that were particularly important for us to remember when we're working with patients. First, there might be efforts to avoid thoughts, feelings, or conversations associated with trauma. A patient might change the subject. They might not want to talk about what we want to talk about with them. There might be a reason for that. Somebody who just found out that they have diabetes may have lost a grandparent a long time ago, and it was a traumatic experience for them. And to find out that they and their grandparent might have had diabetes, and it might have shocked or scared the patient. So they might not want to talk about it. They might want to avoid thoughts. They might want to open up their feelings. They might feel like they might break down. Efforts to avoid activities, places, or people that arouse recollections of the trauma. Something might have happened at a gym, for example, and somebody wants to start working out, but they're terrified to go to the gym, and we were recommending it, or in public places. An inability to recall an important aspect of the trauma, sometimes it gets foggy. They might have the overall gist, and they might have certain aspects of the trauma that was very clear and vivid, and other aspects where they can't even remember. Markedly diminished interest or participation in certain activities. That's important if we're helping somebody make change, that we recognize that. If there's a menu of options, we have to understand whether or not that patient can make changes if they're having traumatic reactions. Feeling of detachment or estrangement from others. Sometimes people isolate. They might avoid people or places that are associated with the trauma. There might be a restricted range of affect. It should be affect, not effect. It's their facial expressions, their mood. They might not be able to express themselves, almost like a numbing. Sense of foreshortened future. Sometimes when people experience trauma, they might not think that they're going to be able to live as long as somebody else. They might feel that they might die sooner. It might be certain aspects of work. They might feel like they're going to get fired. They might feel like they're going to lose their spouse or a child. And that can impact patients making change or working with providers. Persistent symptoms of increased arousal that were not present previously, such as difficulty falling or staying asleep, irritability or outbursts of anger, difficulty concentrating, hypervigilance, exaggerated startle response, motor restlessness. These are several areas that are really important in primary care when we're working with a patient to remember that if they're presenting with any of this, difficulty falling asleep, outbursts of anger, concentration, restlessness, it might actually be trauma responses instead of us jumping to conclusions. For example, difficulty concentrating might not be ADD, for example. There are specific criteria that would have to be met to become a diagnosis of PTSD, such as the duration of symptoms at least 1 month. There has to be significant distress or impairment in social, occupational, or other functional area. Sometimes, actually many times, people experience trauma and they have trauma reactions, but it does not necessarily impair those areas of their life. Many patients and staff can present with some of the criteria, but not enough to meet the diagnosis. They might meet the criteria for acute stress disorder. As stated previously, trauma-informed organizations aim to provide a safe setting where patients feel supported and not re-traumatized. And again, I want to emphasize that it's for patients as well as staff. There are several other reasons why this is important. Increased sensitivity to patient behaviors, language, tone of voice, body language, facial expressions. I would say this is important for coworkers as well. Trauma-informed care also gives us a deeper insight to provider reactions, to understand countertransference and respond when patient is triggered. Countertransference is when we as providers have a reaction because of what a patient is saying or doing. Transference is when a patient's reacting to us, so it can go both ways. Frustration that often happens when patients do not follow treatment, take medication as prescribed, or relapse. There could be a paradoxical response, which means that look like they get worse after we try to help them make change. Trauma responses might impact that. Potential for losing patients from the health center for just not keeping a safe space. And higher quality care. How can a trauma affect staff? There's a term called vicarious trauma, where there's negative secondary effects experienced due to helping people who have experienced trauma. So we hear traumatic stories, and we might go home have a tough time sleeping ourselves because if we heard that story that the patient went through. Compassion fatigue. I sometimes call it empathy is getting raw, where we're walking in somebody's shoes, trying to understand where they're coming from, and we get exhausted. It's not really burnout per se, but it's hard to kind of have those feelings of support and understanding where somebody's coming from. Another reason why, a reason how it can affect staff, may be similar to those suffered by patient, such as intrusive images, nightmares, emotional numbing, dissociative experiences, exaggerated startle responses. There may be changes in how staff perceive, experience themselves or others, such as feeling safe, increased cynicism, disconnection. They might not want to come to work. They might start calling out or getting sick. Vicarious trauma has been shown to increase rates of physical illness, greater use of sick leave, increased turnover, lower morale, decrease in productivity, increase in patient-related errors. It also can make it hard to just even focus at work. So how can we respond? Active listening. We often think we are listening when we actually don't hear what is being said. We oftentimes begin thinking about what we want to say before the other person actually finishes speaking, so we didn't hear everything. We often have automatic thoughts and feelings associated, convincing ourselves that what we are thinking is in fact when it may not be. We all have automatic thoughts, and they're unhealthy thinking patterns. So we convince ourselves because we're having a certain thought or a certain feeling about something that indeed it's true. Continuing with active listening, look at the other person when they are speaking, making eye contact. Let's pay attention to what is being said, the problem as well as their feelings. Don't interrupt. Beware of our own presence, our facial expressions, body language, tone of voice. The words that we choose actually can impact the patient and how they're doing. Use minimal encouragers, like yep, please tell me more, to help somebody expand on what they're talking about. And if somebody keeps repeating themselves, it's clear that we're probably not hearing what they're trying to sell us. When the person is finished, ask for clarification using open-ended questions. Who, what, where, when, and how. Try avoiding asking questions with yes or no responses unless you're looking for just a direct response. If you're hoping for them to elaborate, stay with the who, what, when, where, and how. Avoid asking questions that seem accusatory. Why? How come? Did you? Why didn't you? A lot of folks struggle with what's wrong with why. A lot of times we don't recognize that it can almost feel parental, or it could feel like we're accusing somebody. It's the tone of how we say it. It comes what comes after the why. So I just encourage people not to use it, to try to avoid it, and stick with the who, what, where, when, and how. The purpose is really for the person or the patient to elaborate. Reflect back what the person said. What I'm hearing sounds like you were saying, tell me more about, and defer judgment. Don't discount feelings or perceptions. It's one thing to understand somebody's experiences and have empathy, understand why they're feeling the way they're feeling. It doesn't necessarily mean we condone their behaviors. And if we can recognize that when we're working with a patient, it helps us much more to validate what their experiences are and take the behavior out to stay away from shaming. Don't give advice, and I say don't give advice for moral advice. When it comes to giving advice in primary care, we often give advice, but we do evidence-based advice, something that's factual. You quit smoking tomorrow, you have a better chance of being healthier and having a longer life. If you continue smoking for the next 30 years, you might shorten your life. That makes more sense than saying maybe you should change social groups or go to this church or whatever the case might be. Avoid reacting to what is being said now. Now is all about making sure that we heard what was said. Validate, validate, validate. I cannot stress that enough. It's important to validate somebody's experiences. Again, it doesn't mean we condone their behavior. It does not mean we agree. Always show respect and dignity at all times. Use ourselves as barometer. If we recognize that we're having a reaction, countertransference to what a patient's saying or doing, we have to recognize how we're feeling. If we start getting irritated or feeling sad or maybe even angry, how is that? Why are we reacting that way? And that's a barometer to tell us that something's not working, or it could be the opposite. It could tell us something is working if we're feeling good for the patient, relief, contentment. Empathy, walking in the other person's shoes, ability to understand or feel what the other person is saying, and again, it's not sympathy. And genuineness, we have to be real. Unconditional positive regard, and it's always showing that respect and dignity. So the purpose of today's training, begin to understand how trauma affects patients' lives, how we can be affected, and how to avoid triggering or escalating the problem. This affects staff as well as it does patients. This is Norm Sweet. Please feel free to call me, email me if you have any other further questions about trauma. And Harbor Health is dedicated to provide safe, trauma-informed care. And we're looking at different models and how we can really enrich the work that we do, the safeness and the safety for the patients as well as ourselves. Have a good day. Take care.